Welcome to Doc podcast. My name is Abbas Shafi, gastroenterologist.
And I'm Rob Hoyer, medical oncologist.
This is a podcast about lifestyle medicine, disease prevention, and longevity.
This podcast is provided for informational purposes only. It is not medical advice. Please consult your physician for individualized therapies. Hi, everyone. Welcome to episode 11 of the Doc podcast. Today we'll be talking about functional bowel disorders. First, a few housekeeping items. We're very happy to report a new website we have created. It's called doc2doc.health. That's DOC, number 2, doc.health. And there you can see all the episodes and also leave questions and subscribe. So when there's a new episode, you'll get an email or your choice of communication for notification. We're really excited to talk about the topic today. And this is something that is a little different than what we've talked about before. A lot of the diseases and conditions we've talked about are very serious disorders like cancer or pancreatitis. And today's topic is a little different. It's called a functional disorder, and that's a disorder characterized by symptoms, but there's no actual disease or condition that's identified. It's in fact all the functional bowel disorders are marked by normal endoscopic procedures and normal testing. That does not mean they're not real. The individuals with these conditions have real symptoms, and I was really interested to learn, and we'll all be able to learn about management of these conditions via lifestyle medicine. And this is an area that it's Abbas's specialty, so I'll let him kick it off.
And thanks, Rob. The Irritable Bowel Syndrome, as well as functional bowel disorder, is one of the most common visits to gastroenterologists. Worldwide, about 5 to 10% of people suffer from this disease, and possibly based on the region, from 20 to 45% of the gastrointestinal visit is due to one of this form of disease. Even with that, we only see probably the top of the iceberg on this disease. So it's a very common. It is can be from mild to moderate to debilitating disease, and the key diagnosis of this people, you have to exclude the other disease that can be mimics functional bowel disorders, such as malabsorption, let's say celiac sprue, or colon cancer, bowel obstruction, inflammatory bowel disease. All of this have to be excluded. So when a patient present to his or her physician, and complete history is probably the most important thing, as well as physical exam, and based on the age, deciding what test to be done. This is commonly is below age 50. So this is a chronic condition, and unfortunately, I will go to more detail on this. The patient, they will go doctor shopping from one doctor to the next one, and unfortunately, because of not knowing the underlying etiology, end up doing unnecessary surgeries, such as hysterectomy, GYN surgery, gallbladder surgery. So it is a very common, and the key diagnosis is to exclude the alarming symptoms, and we'll go through that in more.
Do you think these conditions are marked by a normal, well, we consider them, they have a normal workup, we exclude other conditions, but do you think that perhaps we just don't know how to define them? For example, it may be an anatomic or an abnormality that we just can't identify yet.
A possibility. It's a majority of this one is worldwide, and is based on the culturally, as well as some of the, but maybe 10% of this due to post-infection. We have a subset of patients that they know exactly, they had to travel out of the country, they got bacterial gastroenteritis, and after that the symptoms started. So some is associated with that, some also with the psychosocial stressors. Today, particularly in our environment, see separation from divorce or trauma in childhood, or many other things can contribute. The exact etiology we do not know, but there is subset of them that can be related to stress situation, lifestyle, diet, and as well as I mentioned, sometimes due to bacterial and sometimes viral infection in the gut.
It just seems that this is screaming microbiome abnormalities or dysbiosis, as we call it, which is abnormalities of the microbiome.
That's going to be a corporate factor as well. And some people, and what's worked for one person does not work from the other individual. So when a person presents to their physician, there's some key question. I think that they should be prepared to ask the question. The key things, a good history. One, they have to give when they started, how they feel. Majority of this problem is done during the day, and I tell my patient when their conscious wakes up, that's the gut awareness awakes, and then based on what they're eating and their body position, very seldom this has a nocturnal symptoms. That's one of the alarm. If somebody has symptoms at night, then you have to make sure there's nothing else going on. And of course, as I mentioned, the age of onset, majority of these are below age 50. And then you look for other alarms such as weight loss, whether it has blood in your stool, the blood in your stool. Look at the appropriate history for the inflammatory bowel disease in the family, colon cancer, malabsorption such as celiac. So you need to exclude all of those. So after a good history and physical exam, commonly the physician will order some basic blood work, which is commonly done starting with basic blood work based on the age. As we get closer approach to 50, we do more diagnostic tests. So at the beginning, you do what they call a CBC, a complete blood count, and a CMP, which is a chemistry, as well as you do celiac spruce serology, because today's many people, they think they have gluten sensitivity, mostly IBS, and diet will help with that. We'll get to that as well. And sometimes female thyroid abnormality, you do that. If it's persistent diarrhea, you do a stool study to make sure there's no infectious etiology or in the blood in stool. Then after a basic routine, you can trial it and the diet. And diet is very different from individual to individual. So in general, the common functional bowel disorder is IBS, which is mostly a chronic disease, and these people can be predominantly diarrhea, constipation, or alternative. So based if the symptoms it is, the diet can be completely different. People with diarrhea, sometimes the fiber can cause them have more diarrhea, while people with constipation may improve that. So you have to individualize the diet, but once you can try to give a diet, but if they do not improve, then further testing such as like a colonoscopy to rule out inflammatory bowel disease, colon cancer, and then if it's persist, maybe a CT angiography or an X-ray of the abdomen to make sure there is no other etiology for the symptoms, and then you will see how the patient does. And as I mentioned, this is a common disease throughout the world. About 5 to 10% of the population in the world suffer from this. Majority, they are less than age 50. To exact diagnosis is somewhat challenging, but there is a criteria called Rome criteria, which has developed to help the diagnostician to help to diagnose that. And this is very simple. One is you have to have at least 1 day per week for past 3 months having the symptoms. and follow one of these criteria. Number, and the other thing has to be one, the constancy of the stool has changed, and the other one is frequency, two or more of that can help us to the diagnosis. So when you diagnose a person, again, you have to go to some alarming symptoms. Number one, if they're above age 50. Second, weight loss, rectal bleeding, fever, nausea, vomiting, abdominal pain, that especially not related to the bowel movements, diarrhea, particularly if awakened from sleep, anemia, recent travel. So all of these are the symptoms that commonly alarming for that. As I'm going to recap the test that we can do against CBC, SCMP, thyroid, and celiac with stool studies. The first role, if they're close to age 50, we do a colonoscopy. Then if the patient persists, X-ray or CT scan of the abdomen or an upper endoscopy. Other thing that through the time that you have to rule out is like lactose intolerance, which is we can do a breath test as well as SIBO, or called bacterial overgrowth, as well as the stool study for infectious etiology. The treatment of this again is based on the individual. There's no single diet will help individual, but you have to get a diary of their diet and frequency of their meals and what they're eating. Unfortunately, majority of people with IBS, they do not eat frequently, so they try to avoid eating, try to avoid going outside, and then when they eat, then subsequently, these symptoms can be worse. So frequent small meals, stress management, avoiding triggering food. Sometimes some of the patients, they get worse with high fiber, but drinking plenty of water, exercise, getting adequate sleep, stress management helps a lot with the mild to moderate cases. Certain food like high gas forming food, and gluten, even if the gluten test was negative, sometimes limiting or decreasing the gluten can help with most of the people with their symptoms, particularly if they're gas and bloat and diarrhea. Other people, there's a diet called FODMAP diet that certain carbohydrate that produce a lot of fructose and lactose and other things that can help them. And many patients, they will try it, and some people, they get tired of it and they go back to other things. So there's not exactly one treatment for everybody.
What about dairy? Do you find that dairy has an impact, eliminating it, or
we always give a trial, particularly
Okay.
people with gas and bloat and diarrhea.
Okay.
So dairy and gluten probably has been the most studied, and and particularly dairy is. If you look at the human history or any mammalian history, only humans, they eat milks and from other animals. So and depend how you consume the dairy. So commonly, raw cow milk is probably one of the most, and when you ferment it to cheese and yogurt, sometimes change the texture, and that can be, sometimes people benefit from it, and if it's milk from the goat or sheep, is even more tolerated because they have plenty lactase in it. So it's individually, some people, they cannot tolerate at all no dairy products, and it based on the cultural and genetic background as well. So we know some American Indian or Chinese, and this has not adopted as much, so they be more intolerance to that. So people actually be whose tolerance to the milk, so more European, they can tolerate because of exposure to that more. So that's one of the things. And again, gluten, we exclude the celiac, but however, excess of gluten, particularly the way we make the gluten today, and combination with dairy sometimes cause severe symptoms. So those are all sort of for mild to moderate cases can be beneficial.
Abbas, what other medicines or treatments have you found successful, and do you have any case examples you can let us know about, or things you found successful in some of your patients?
Some of as mentioned, it is not one treatment fix for everybody. I think talking to the patient, getting an accurate history of the dietary intake daily, and particularly in Colorado, hydration. I start with the basic treatment. That's number one is drinking adequate hydration, because that's, I think, one of the key factors. That secondly, avoiding processed food, so particularly substitute sugars. So having a good meal plan throughout the day. And then another thing is toileting. Calmly, when you eat a meal, you get the stomach that send a message to both gallbladder and colon to empty, and a lot of people get severe spasms. And it's very important to go to relieve, whether they have bowel, it's not important to release some of those spasms. So other basic remedy, of course, biofeedback and stress management, and some studies in Asia showed that abdominal yoga and meditation can be sort of help. Then once we establish that, then we look at people like, for example, with constipation, introducing some fiber like psyllium or any fiber supplements. And when you're taking the fiber, it's very important that have adequate water. In the first few days, you may get more irregular than you need, particularly with people with constipation. That helps a lot, especially if they're not taking adequate fiber in their dietary things. With the constipation, also laxatives like such as magnesium or miralax, which is polyethylene glycol, can help. For those people that associated with conditioning, they worry that when they go somewhere to get diarrhea, sometimes over-the-counter antidiarrheals like Imodium, particularly people, these are mostly very functional people, and if they have to give a speech or they have to travel through the plane, they're really worried about their lifestyle. So we ask them to use an anti-diarrhea to get them through that stressful situation, and may not need it at home. Then if that persists and the symptoms does not get improved, there are many anticholinergic like Bentyl or dicyclamine for severe spasms when they go to episode. And this you have to warn the patient that can cause blurry vision, so they do not take in and drive, and each person is different. Other thing for anti-diarrhea, sometimes you use cholestyramine, which is bind to the bile salt, particularly for people they have gallbladder out and causes their diarrhea, so it binds to their bile salt and cause them better. Then after that, we'll get to the tricyclic antidepressant or SSRI, if this is associated with anxiety or depression, or these are for moderate to severe cases. So we incorporate those, and at the same time we try to get some psychological help as well as biofeedback. Other medication has been tried recently is like Lyrica or gabapentin, but truly the treatment of this is starting with lifestyle modification, stress management, diet, but in the severe cases, these are for moderate and severe cases, we have other medication like Lotronex, which is allosterone, and Vibrizi, as well as sometimes we'll try for, if we worry about that have bacterial overgrowth, we use Xifaxan. We think that if this has to do with gut flora. Other medication for constipation, we use Amitiza or Linzess, which is inclusive fluid released from the small intestine, and that can help them with their symptoms. These are particularly for people with constipated type of the IBS.
You mentioned something called abdominal yoga. Could you describe what that is?
This is more used in East than in United States. So because of the gut and brain relationship, this is one of the major possible cause of IBS, and maybe that's post-infectious, is to do with inflammation of the gut and nerves. And by doing deep breathing and relaxation, it may be able to individual. It doesn't work for everybody to relaxes the gut and responds to the food and other things. And there's certain people that can Google the abdominal yoga used in India, Sri Lanka, many other countries. And is a part of the treatment, and for some people it can help with preventing the trigger mechanisms and be able to sort of decrease the acute spasms. For severe cases, maybe a part of that, but may not be the treatment. Other treatment has tried the alternative medicine. People that have tried is hypnosis, peppermint. Many study has done, and I'm from Iran, and this is mom's remedy for any kid's tummy aches. So anytime you have tummy aches, come home, they give you some drink of peppermint, ask you to lay down, and usually by the time you wake up, your tummy aches is gone. So sometimes we use a short course of probiotic, which is very popular these days. Probiotic and irritable bowel syndrome is not a long-term treatment. I know many people have used it for many years, and so in newer study shows if you try it for 4 weeks and it's improved, if it's not helping you in 4 weeks, then it's very expensive and you should not continue that. I think the stress reduction by any means of whether it's yoga, whether it's traveling. We have many patients that when they're traveling or and the situational thing is not there, they say, I go on trip, I eat many food that doesn't bother me. Then I come home or I go to work, everything bothers me. So those are the trigger things. So we know there's a huge gut and a mind relationship. So those are the important things that the individual can do, and then if it doesn't work, to communicate with their physician for appropriate medication.
Could you comment a bit about if there's a gender predisposition to IBS?
Yes, IBS affects almost all the individuals, including children, and worldwide between 25 to 45 million. Actually, in the United States, between 25 and 45 million suffer from IBS. Among this, majority study shows in Western culture, particularly in the United States, 2 out of 3 are female. However, some of the other countries, they have done multinational studies, like for example in Sri Lanka and India, male-female ratio is much closer. And some countries the male is predominant, but in Western culture, particularly the patient that we see here, majority are female, and on an average, as I mentioned, about at least 25 to 45% of the visit that we see in our clinic are related to IBS. And among all of this, these are very few people they seek actually help. And unfortunately, because of the persistent symptoms, they shop around and possibly I think one study shows between 47 to 55% of people with IBS, they get unnecessary hysterectomy or ovary or gallbladder surgery. And again, we mostly see moderate to severe symptoms. Most people with mild syndrome, they think they're allergic to a certain food and certain things, and they deal with it, and that's really affect their psychosocial. Is one of the number of causes that children are not going to school or not going to work, affects under economic factor, under traveling. So the psychosocial impact is significant. One of the key recommendation: don't change from one drastic diet to the next, because the GI tract is super sensitive. If you are a vegetarian, suddenly don't go eat fatty meals, or when you're fasting, don't start with the big meal, because those are the thing that causes sudden release of many chemicals in the gut and causes spasm. One of the perfect example, one of our nurses, that she is very healthy and vegetarian. She's very aware of her gut, stuff like that. It was her birthday, and her parents asked him to go for a birthday party to one of the local restaurants. And father, he says, you're smart, you're a nurse, you always worry so much about your diet. Today's your birthday, you should elaborate. Let us buy you a cheeseburger. Let's have fun together. So she ate the cheeseburger, and they said, well, you have to have some fries. And then, of course, they brought, there was that the cake for the birthday party and some ice cream. So when she was coming from Denver to here, the middle of the road, she developed the worst severe experience of abdominal pain, nausea, vomiting, diarrhea. So it's such a shock to her system that actually she had to be hospital for several days to get rehydrated. And then they did extensive mortality defend. And then when I saw her, I said, well, guess what? This is, you maybe tolerate those as a child, but you have went to such an extreme diet. Now these all become a trigger food. So sometimes people have to be aware of the certain condition and don't jump from one to the next. They may tolerate, but they need to introduce these things slowly. So unfortunately, this is a very common disease, affect many people, and the key thing, you have to rule out anatomical or etiology, that you cannot. I've seen many people, they told them they have irritable bowel syndrome, and end up having Crohn's or ulcerative colitis, which is more of an inflammatory disease, or they've had gallstones, or the most common is missing celiac, which is easy to be with a diet. And so you have to exclude the thing, and these are the people that you need to spend time and time for prevent them from getting any complicated surgery, and hopefully you have a long life plan for it.
And I would just add a quick note to our listeners. If you're interested in an overview of the microbiome, you can listen to our episode on that. It's available on the podcast list. So besides IBS, are there other functional bowel disorders?
Yes, we see many GI symptoms that beside the chronic symptoms, and I'll go through some of them. I'll go from anatomically down, so sort of I can clear some of this. One called global sensation, which is people feel like choking, and this is probably one of the most common. Most people have experienced once or twice in their lifetime, when you get the bad news or your stress, your voice changes, and this is people have frog in their throat, stuff like that. That's for some people that can be very, very severe. And they will have a cough at the time. Sometimes they have choking on their own saliva. So that's one of the global systems. The other one is esophageal spasms. Esophageal spasm completely can be just a spastic things. I tell patients like a Charlie horse in your leg, or leg spasms. And when you experience the pain 10 out of 10, and you go to emergency room, you can do CAT scan, MRI, but it's all normal. What the feeling is true, but there's, we do endoscopy, other things, and there's nothing there, or esophagram. But esophageal spasms is similar things. When you get to the stomach, cyclic nausea, vomiting, or chronic nausea, that is another thing. Particularly these days, we see that a lot with daily use of marijuana and cannabis, particularly the edible types, and that what it does causes a gastroparesis, which is slowing down the stomach empty, and then when that get overwhelmed, they go to this nausea and vomiting episode, and sometimes comes chronic nausea. Some patient, they get biliary spasms, which is spasm of the gallbladder, and they think that's says, well, my mother had gallbladder disease, my sister had, and must be there, and they end up with they do HIDA scan, and if it's marginal, or not all of them, but some of them, they get the gallbladder out, and then consequently then they get diarrhea. These are the common thing that we see in the GI tract. Of course, the bloating post meal is sort of more like IBS type of symptoms, and that's again due to diet. Majority of these things have to do again with hydration, diet, and stress. And as I mentioned, post-infection, about 10% of these things have to do a post-infectious etiology, which is about 50% goes through the time they resolve, and we don't know the etiology. That could be the inflammation and body response to the infection, which is on the stool studies, on labs, they're all gone, but probably is a very subclinical inflammation that affect the neurons, and the neurons is like herpetic neuralgia that we see in the skin. All the vesicle and all that is gone, but for many months you will feel the sensation of that area. I think similar thing happened to the gut in those post-infectious, and people that it's a 50% over times they get better, but some is a chronic lifetimes symptoms.
Yeah, just a fascinating overview. Thank you so much for that. And I learned a ton, and it's particularly the lifestyle medicine, both for the treatment, and also theoretically could help prevent some of these conditions, perhaps by just having a regular but varied diet, and just listening to your body. I think it sounds like a common theme here, and there's it's not necessary to go on an extreme diet or make huge changes. It takes months sometimes weeks to months for the gut to adjust to a new diet. So changing weekly or even bi-weekly is way too frequent to change your diet significantly. Small changes are okay, but big changes.
Right. And what I tell my patient, what you're feeling is true. The patient, the symptoms for them is true, and everybody looking for a structural abnormality. We can fix, ulcers. We can release the bowel obstruction. We can treat Crohn's. We can treat ulcerative colitis. We can remove the cancer or bowel obstruction. And everybody's believe they have something that mimics that, but unfortunately, it is a more of a spastic, and I call it invisible disease. So you have to eliminate what they think, and by elimination, and then come to a conclusion. This is a functional bowel, and based on the person's symptoms and with multimodality, hopefully they will have a good functioning life and they can cope with it.
Thanks everyone for listening. We'll put some info and some articles in the show notes. And once again, if you have a comment or a question, and feel free to check out our website. It's doc2doc.health. And we'd love to hear your feedback. And if you have a few minutes, please drop us a review, and it helps others to find the podcast in the search algorithms.
Thank you very much. Have a healthy life.